Hi, this is Alan Gassman, and it's 5 p.m., and we are starting this webinar on how the new pain clinic regulations affect your medical practice. We want to thank you for joining us. Our speakers today are Lester Perling, the esteemed healthcare lawyer from the Broad & Cassell law firm in Fort Lauderdale, my hero, Dr. Singh, the leader of Access Healthcare in Spring Hill and throughout Florida, and I'm Alan Gassman. At Gassman Bates & Associates, we represent a number of physicians in business and estate planning matters and get a lot of help from Lester Perling on healthcare matters and from Dr. Singh about learning how things really work in the healthcare system. Dr. Singh, I thought we would start off by just letting you give a brief introduction on what doctors should be looking for and thinking about while they listen to the webinar and how this is affecting your practice.
Thanks, Alan. I appreciate this. I think the most important issue is for physicians to figure out is how will this affect their practices and what all do they need to do to register if needed for any of these requirements. If they're a pain clinic or if they are treating the chronic non-malignant patients or anything that is not included in that diagnosis. And it's a little tricky, but I'm sure Lester will go into that. What are the practical issues that will affect each practice? How are you going to document the pain level, the need for medications? That will be the key in really defining whether it is truly chronic non-malignant pain and if the treatment is in the regular course of that condition, whatever that means, since it's a very subjective criterion. But still, documentation will be the key. For example, a new patient comes and already is on pain medicines. The first instinct should be to find out why the patient is on pain medications. Or if a patient comes and he has new pain, the first instinct should not be to just start with a narcotic, but try something else. Maybe consider rehab or other medications, non-steroidal, anti-inflammatory, if their condition allows. So how are you going to safe keep your prescription pads, how you're going to follow up and make sure they sign a pain contract, how you're going to communicate with other specialists who are taking care of the patient, because every day all of us know that a patient will go to different specialists and then collect pain medicines from them. Sometimes the pharmacist will let us know and sometimes they won't. And so I think it behooves us as physicians to make the extra effort to make sure that we are aware of this, our staff is aware of this, and we consistently document and stay compliant as far as possible, because remember, after all, these drugs are controlled substances. We are used to writing them a lot, but eventually when somebody starts looking at our charts, they need to know that the patient really needed it, what kind of assessment we did, and what was the thought process behind giving the pain medication. This will be extra work, this will be an extra effort, but I believe if we do it right, it will make us safer and more compliant. Having said all this, now I turn it over to our expert, Lester Perling, and at the end of it, if I need to add a few pointers for just practical tips how to safeguard your practice, I'll be happy to do that.
Excellent. Well, this is Alan again. I'm going to say a couple things before Lester. And I think you pointed out a very important thing, and that is this is really going to raise the bar a little bit on the standard of care that all doctors are going to be looked at as far as how they treat pain patients. Although there's going to be a lot of exceptions to the rules that don't formally apply to doctors, I think from a jury system standpoint and from a standard of care standpoint, Florida is certainly raising the bar here, at least indirectly. Now, I have the PowerPoint here, and all attendees are able to look at the PowerPoint and also print it out. If you have any technical issues, you can email Janine, Janine, at gassmanpa.com, or call her 727-442-1200 extension 8, and she'll help you out. Also, before we forget, if anyone would like to see Dr. Singh's draft protocols of how his 90-physician practice is handling these new rules, you're welcome to get them, and then we would just ask that you give us input as these continue to develop. Now, on page 2 of the PowerPoint, we have the history of this new law that Governor Scott signed on June 3rd. It becomes effective July 1st, so in Florida we're becoming very aware of this new law. And then just a few definitions on page 3. We have these different substances in schedules. Your Schedule 1 substances, which you can't prescribe anyway. Your Schedule 2 substances, which they are working to control here, which include the morphine and the oxycodone. And the Schedule 3 substances, which are shown on page 43 of your materials. So we even have also on page 44 the Schedule 4 substances, which are not controlled, just so you can get an idea of which substances are problems and which substances are not problematic as far as categorization here. It's the Schedule 2 and the Schedule 3 substances that they are regulating. And then we have this definition of chronic non-malignant pain. That's pain that is unrelated to cancer or arthritis. It persists beyond the normal course of disease or injury that's the cause of the pain, and it's more than 90 days after surgery. So what the regulators are telling us is they're not going to regulate cancer pain. They're not going to regulate arthritis pain. They're not going to regulate pain in the first 90 days after surgery. And they're not going to regulate this amorphous thing called pain that is the normal, that persists beyond the normal course of a disease or injury that is the cause of the pain. So clearly there's going to be a lot of lobbying with our Department of Health as to exactly what's going to be regulated under that definition. Then we have a pain management clinic, and that's going to be the clinics that have to register and follow all these rules. We have a designated physician. That's going to be the doctor lucky enough to be registered with the state as the person making sure that all the rules are going to be followed. And then we have something called a medical specialist, which is not even defined in the bill. And that also is going to cause some questions under certain statutes. Now, at page 6, I have a few questions that you have to ask yourself in order to determine how to navigate this statute. Number 1, are you an exempt physician? There's a definition of exempt physician, and if you're an exempt physician and you own the practice, you may not have to follow these rules. If you're not an exempt physician, then other rules may apply. Third, there are some rules that apply to all physicians, even if they're exempt. So you may read that you're an exempt physician and not worry about it, not realizing that certain prescription rules still apply. Also keep in mind under these new rules, nurse practitioners and physician's assistants cannot prescribe these controlled substances. Number 4, whether you're exempt or not as a physician, does your organization have to register as a pain clinic? What organizations are you working for, and do they have to register? And if they have to register, you need to make sure they register so you're not a co-conspirator. D, are there multiple clinic locations? If so, then every location has to have a separate registration. E, are you the designated physician or who will be? Then on page 8, possible suspension or revocation of clinic registration, and also automatic loss of medical license for 6 months if certain violations occur, whether they are intentional or not. So as we go through these materials and as you see other materials on this topic, you need to think through these questions. I would not rely on this webinar or any one webinar or authority to make sure that you're in good compliance. You want to be very careful. Now, the new law does have many exemptions for certain categories of physicians. These are board-certified anesthesiologists, board-certified physiatrists, and board-certified neurologists. If they're board eligible, that's not enough. They need to be board certified. There are also categories of exemption for surgeons prescribing during the first 90 days following surgery, and some rules on that we're going to talk about. Then there's a designation of pain management certified doctors. For MDs, that's ACGME accreditation. For osteopaths, that's AOA accreditation. If you have this category, you may be exempt from some of the rules, but others may apply, so you still have to be careful. Then on page 10, number 4, the ABMS designation for MDs. And then number 5, doctors who only prescribe for patients within 90 days of surgery, cancer patients, arthritis patients, or again, patients who are still within the usual course of disease or treatment that is the cause of the pain. Now, many doctors in this situation are not going to have any responsibility other than the prescription logistics that I'm going to talk about in a minute. Other exceptions on page 11, drugs labeled as a sample or complementary drug, Department of Corrections work if you're working in the jail system, surgical procedures, and again, up to 90 days, which they tell the surgeons 14-day increments, up to 5 14-day increments, that's 90. Approved clinical trials, licensed methadone clinics, and hospice patients. If you're involved in these activities, you can look to see how the exemptions apply to you, but you want to look very carefully because they don't always apply. Okay, page 12. For all physicians, whether you're exempt from these rules or not, you have new prescription writing transmitting requirements. Your prescriptions have to be written on standard counterfeit-proof prescription pads produced by the Department of Health, or you need to be electronically prescribing. Certainly, electronically prescribing is probably going to be the preference. Secondly, you have to treat your prescription pads now like they're petty cash. You have to account for your prescription pads, the control and security of the blank prescription pads. Any loss, theft, or breach of authority requires notification of the Department of Health within 24 hours. So these prescription pads are much more than just monopoly money now. You have to be very, very careful. And we have some notes. Of course, nurse practitioners and PAs cannot be prescribing these substances. Second, doctors working in a pain management clinic still have to follow the exhaustive documentation from slides 21 through 26 that Lester is going to talk about. Okay, page 13, know whether you should be organized as a pain clinic or not, which I've mentioned before. And note number 4, even if you're not required to follow the protocols on slides 21 through 26, maybe it's the best thing for your patients if you do. Maybe it's the best thing for your malpractice insurance rates if you do. So I would still consider these protocols when we get there, whether you're really required to follow them or not. Now, page 14, when will your organization have to register as a clinic? If either of the following two things is taking place, then you have to qualify as a clinic unless one of the exceptions applies. The first one is, are you advertising in any way that you do pain management services? Does the word pain or anything like pain show up on your website or in your mailouts? Or are you in a catalog, or are you in a yellow page ad that mentions pain? If so, you may have to register. Secondly, the alternative test, do a majority of your patients get prescribed these controlled substances for chronic non-malignant pain? And if so, you have to register with the state of Florida as a pain management clinic. Now let me mention that every county in the state of Florida can have a different rule on pain clinic, and many of the counties do have their own rules. So you have to navigate within the county as well. Now, the main exceptions to pain clinic registration are where the majority of patients are receiving these prescriptions for the first 90 days within surgery, cancer, rheumatoid arthritis, or, again, the usual course of the disease or treatment that is the cause of the pain. Now, obviously, the cancer folks and the arthritis folks had good lobbyists. And other areas obviously didn't have such good lobbyists, and they'll have to be lobbying with the state agency now. And a lot of people are going to be in a gray zone based upon what they're doing, and people are going to use less of these controlled substances than they used to as a result of this law. Now, page 15, further exemptions. Hospitals and ASCs, surgical practices where most of the physicians provide surgery, publicly held companies, they had their lobbying done, accredited medical schools, clinics that don't prescribe controlled substances for the treatment of pain whatsoever, charitable organizations, 100% board-certified, specialist-owned practices where interventional pain procedures are routinely used. 100% board-certified anesthesiologist, physiatrist, or neurology-owned practices. So if you have this board certification and you're the 100% owner, you don't have to register. Now keep in mind, if you're a client of our firm and we've put your stock into joint names with your spouse, and your spouse is not board certified, or if we've issued 3% of the stock to your children or a trust for your children, or 10% of the stock is owned by a doctor who's not board certified, then you will have to register as a clinic or transfer the stock before July 1st. So that's an important area for confusion. Page 16, the pain clinic registration requirements. Each location must be separately registered. Any change of ownership will require a new registration, and each location is going to have a designated physician. Okay, I'm going to turn this over now to Lester Perling. As I said before, Lester Perling is an excellent healthcare lawyer with the Broad & Cassell law firm in Fort Lauderdale. We go to him for help quite often. And Lester, I hope you can clarify a few of the things that I've said and then use the next 15 minutes or so very productively to give us some knowledge in this area.
All right, thank you, Alan. Picking up a little bit where Alan left off, I'm not going to go over each of these line items, but it's important to note that if you're a physician and you are working in a clinic that does have to register as a pain clinic, there has to be within that clinic what's known as a designated physician who is legally responsible for complying with both registration requirements and operating requirements. So that's going to be a position that has a fair amount of responsibility. Slide 16, and I think carrying over to primarily slide 16, has the obligations of the, some of the obligations of the designated physician. The clinic is obligated to report a change in the designated physician within 10 days. So the Department of Health wants to keep pretty close track of that. Continuing on slide 17 and number 4, you'll see the reasons for denying registration. A is interesting. It's any clinic not 100% owned by a licensed physician or group of licensed physicians. So basically what you're seeing there is an effort to basically eliminate the clinics that are not full-time physician-owned practices, even though some of those might not be exempt from registration because they're not owned by the right specialists. Nonetheless, they'll at least be owned by physicians over whom the Department of Health has a lot more control from a regulatory perspective than if they're owned simply by individuals. Now, one thing to note, if a clinic is owned by a non-licensed person, you also have to consider the healthcare clinic licensure statute, because the clinic may both have to register as a pain clinic and be licensed as a healthcare clinic. And that law has been around for a while, but this does not replace that particular requirement.
So Lester, what do you think is going to happen here with these non-physician-owned pain clinics? There are many of them.
Well, it'll be interesting to see, because the Department of Health can't really act arbitrarily or capriciously. There'll be some constitutional arguments, potentially anyway, with regard to under equal protection, under an equal protection argument. So it'll be interesting to see what happens. I think that the Department of Health, and this is just a prediction, I have no basis to say this, but it wouldn't surprise me if the Department of Health does start trying to deny applicants who are not owned by entirely by physicians of one sort or another. And then it will also not surprise me to see some of those denials being appealed initially through the administrative process and then ultimately into court. We'll see. I think a lot of the registration requirements and the new tracking registry is probably going to cause a lot of the individuals who are not, not physicians to close down these clinics anyway, which of course is the ultimate goal of the legislature. So we'll kind of have to see how that goes.
Okay.
Page 19 and 20 talk about penalties and violations. These are the bad things that can happen to a clinic and the designated physician if there's non-compliance. And I think the important thing here to note with regard to the designated physician is that there are penalties for them as well as for the clinic. So if you're asked to be a designated physician in a clinic, you need to think about that carefully and probably get some decent legal advice. All right. Starting on page 21, there's some rules for physicians working at registered pain management clinics. That's actually a little bit misnomered in the slides because, in fact, there's two different regulatory schemes going on here that I want to differentiate. And this is kind of, like I said, going off slide a little bit, Alan, so in case you're trying to follow along with me. Besides the individual physician obligations concerning prescription blanks themselves that Alan talked about that will apply to all physicians, there's some other requirements that apply to all physicians who prescribe controlled substances for the treatment of pain, even if they don't work in a pain clinic. So for example, an internal medicine specialist who every once in a while will prescribe a controlled substance for a patient with chronic back pain would be a pretty good example of what we're talking about. But any physician who does prescribe controlled substances for the treatment of chronic non-malignant pain must designate himself or herself as a controlled substance prescribing practitioner on their Department of Health profile. And that becomes effective on January 1st of 2012. As those of you who are physicians listening know, and some of you who aren't physicians know, each physician does have a profile with the Department of Health that has to be updated periodically. And now this is another aspect that will have to be included in that profile. Then there's also a list of basically practice rules or standards of practice that have to be followed by any physician who's prescribing a controlled substance not for the treatment of non-chronic, or the treatment of chronic non-malignant pain, rather. And I'll talk a little bit about those. The statute specifically, and they are listed actually on 21, 22, and some subsequent slides. Just the slide is incorrect when it says they only apply if you're working in a pain clinic. First off, the statute notes pretty prominently that it does not supersede the level of care, skill, and treatment recognized in general law. So to the extent that the requirements of this statute are less rigorous, then general law still applies. A couple of the requirements I'll talk about specifically. One is there has to be, of course, a complete medical history and physical examination before treatment can begin, although the components of it are left to the judgment of the physician. However, there are some minimum requirements that have to be in the record. These include the nature and intensity of the pain, the history of the treatment for pain, any underlying coexisting diseases or conditions, some psychological documentation, history of substance abuse, that sort of thing. And each individual who prescribes pain must develop a written plan for assessing the patient's risk of abuse. And patients who have a high risk of abuse may have to be referred out for consultation. Each patient has to have an individualized written treatment plan. The physician must discuss the risks and benefits of the use of controlled substances with each patient, including physical dependence and its consequences. And each physician is required to use a controlled substance agreement that outlines the patient's responsibilities. And those include things like the number and frequency of refills, patient compliance issues, things like that. So as you can see, the physician who is not in a pain clinic but is going to prescribe these medications has a lot of obligations, and there's more that I haven't addressed just for lack of time. So don't be lulled into thinking that if you don't work in a pain clinic, but you do, even though you do prescribe some of these drugs, that you're basically scot-free, because you're not, unless you're fortunate enough to be one of the exempt doctors that Alan listed earlier: board-certified anesthesiologist, physiatrist, or neurologist, board-certified physician who has surgical privileges at a hospital or ambulatory surgery center and primarily provides surgical services. Those particular physicians are exempt from this registration requirement. Now, getting back to the slides, as I mentioned, the issues on 21, 22, 23 are applicable to both physicians in and outside of pain clinics. The Board of Medicine does have published rules currently with regard to pain medicine, pain clinics, and some standards of practice for physicians. Those rules were developed before this bill was passed. They may not be consistent with this bill. To the extent that those rules are not consistent with this bill will trump those rules. So that's important to remember. You've got to look at those rules, those existing rules and regulations, in conjunction with this bill. The bill also authorizes the board to create some new rules, and I'm sure the board will be revisiting the rules it's already published and revising them, in accordance with this bill. Again, page 24 gets back to some of the medical record requirements. Won't go into those in detail. We talked about the designated physician. The designated physician, if you look on page 25, is obligated to ensure compliance with all of the listed facility and operational requirements. Those are on page 11. So these are things, the physical requirements for the space in which the pain clinic operates. So the statute covers more than just the medical aspects of the law. So as you see, going on to page...
That's quite a burden for a doctor working in a clinic to make sure that the emergency lighting and communications is working.
It is a burden, and I think it's something, it may be in part intended to also have a chilling effect on pain clinics operating. Because if I were a physician and I were asked to be a designated physician in a pain clinic, I think I'd be kind of reluctant to do so, because I've got a lot of obligations, but I don't have much control or authority, or any control or authority really over the organization. So all I can do is sort of insist that things get done, and if they don't get done, resign and get out of that situation. And I think that will have a significant chilling effect in terms of clinics being able to operate, at least those that are not, medical practices. One important note is that this law now prohibits the dispensing of Schedule II and Schedule III controlled substances from a physician's office, other than the exceptions that Alan noted earlier, such things as methadone clinics, certain other types of clinics. Other than that, and this is another big deal, a lot of the pain clinics now make their money by dispensing the medications. They don't make the money on the medical exam. In fact, the medical exam is often done very cheaply. They make their money on dispensing the controlled substances. They can't do that anymore. And that's going to be another major motivation for people to get out of this business who are just operating pain clinics, because the real profit maker is as of July 1st, that's going to be gone. The slides go into, again, some grounds for discipline on violating controlled substances rules. On page 29 and 30, there's a couple of what are common questions. And Alan pretty much already covered those in terms of partial ownership of the pain clinic still requiring registration. Last slide I'll mention, because we're pretty much out of time, is slide 31, and that's the prescription drug monitoring program. And this is going to now apply to anyone who gets a prescription for controlled substance. So if I break my arm and I go to the doctor and I get a prescription for a Schedule 2 or 3 drug, Percocet or something, I will go into that registry. Similarly, if I'm a OxyContin abuser and I'm getting prescriptions all over town, that should go into the registry. And that caused some political turmoil in terms of privacy issues, but nonetheless, it did pass, even though Governor Scott refused to accept funding from a drug company to help fund the program. And you'll see on slide 31 that in number B there, that it actually, the statute prohibits the use of funds from drug companies to apply to this program. Governor Scott really didn't want this program at all, but he lost that battle, but did win the battle to not accept private drug company money to implement it. So I will turn it over back to Alan now.
Okay, Dr. Singh, words of wisdom for us as we flounder with all these rules.
Well, I think for me as a physician, there are certain take-home messages. And in fact, the slide that you have, I think it is slide 26, where the requirements for a pain clinic rules, no, go one before that, Alan.
Okay.
Further, go further. Yeah, this is a good, slide 24. So what should a physician do when somebody comes in looking for pain meds? And this is really, we know this. We get too busy, but first of all, patients have to have their demographics properly taken down. Often patients are busy, they don't write their name properly down, the staff is busy. We need to emphasize that the demographics is properly noted, patient ID is photocopied, placed in the chart. And then when all this is done, after that a patient has to have a proper SOAP note, proper evaluation, proper history, exam, same things that a good physician would do to any patient. What is the need, necessity, how bad is the pain, what relieves the pain, what has been tried, all those things that we ought to be doing, and when we get too busy, we miss those things. We need to reincorporate in our practice. That is what good a compliant office is about. That is what a compliant note is about. And more and more, actually, this will help. If we really pay attention to it, this will help us all become more compliant if we take it the right way. Yes, it may require extra work and extra expenses for a while, but basically it improves the level of our functioning and it makes us safer, and it will protect our patients. For example, a patient who is on an extremely high dose of Tylenol, once you evaluate them, we've all found patients who are getting 4, 5, 6 grams of Tylenol, and then we have had to cut them down. Any patient who is on pain medicines for a long time should always be reevaluated for a taper. How is the pain level? Is the pain level getting better? And should we try to get rid of some of the medicines? Or at least we should document the attempt to taper. There are some very good ideas in this slide. Drug screen is a very good idea. I often recommend a self-questionnaire for patients where they write down what their subjective level of pain is. Because, yes, we are treating patients who are sometimes abusing drugs, but the vast majority of our patients have real problems. And if we have that documented, what kind of pain they have, and in their own words, in their own hand, it will often complete our documentation and will protect us that we are not just writing prescriptions just for fun. We talked about prescription pads, safety of the prescription pads. We talked about mid-levels not writing prescriptions. But another thing that is coming out of all these legislations that I'm seeing, starting with ACO, starting with medical homes, and even with this, is physicians have to learn to start communicating with other specialists. We have to start sharing our information. If a patient is going to a neurosurgeon and coming to me, and the neurosurgeon is writing a pain medicine, and then I'm writing a pain medicine, and we are not communicating, then we have a problem. So there has to be, we have to work with each other in that, at that level. One physician has to write the prescription, and we have to often have the discipline not to write the prescription. Sometimes the patient will come in severe pain and we feel sorry and we write it. We have to have the discipline. Who is your pain specialist? Who is the neurosurgeon writing the pain medicine? And then we may have to pick up the phone and call the specialist and say, this patient is not better. You need to address it, adjust it. Maybe you need to see the patient, call the patient, or address the issue. There's much to be talked about, and I can go on and on for another 10, 15 minutes, but in the interest of time, I'll pass this on to Alan. But if anyone needs our policies and procedures, we'll be happy to pass it on via Alan. And please feel free to critique it, add things, and give us a feedback.
Very good. Now, we've had a few questions, Lester. Lester, are you game for a couple of these questions?
I am. I'll try anyway.
Okay. One of them is, a doctor has patients who are on methadone for chronic pain. Will these patients have to be referred to methadone clinics?
I don't know that the bill specifically addresses that. I mean, methadone clinics are one of the exceptions, though, with regard to dispensing. So they have to be a licensed methadone clinic. So, yeah, I guess the answer would be yes if the doctor had been dispensing the methadone and the patient wants to continue obtaining the methadone where it's being dispensed. But I don't know that, I haven't reviewed the bill for that specifically, but I don't know that it requires that these patients be treated by methadone clinics specifically, or that they can't be treated in a physician's practice.
Right. And another question is, are there protocols for drug testing in an internal medicine clinic? And I assume that we'll look, but I think the statute would probably say any legitimate drug study, right?
Repeat the question.
Are there protocols for drug testing in an internal medicine clinic?
I'm not sure if that question might be whether or not the patient should be tested to see if they're using drugs, as opposed to a clinical trial, which is a horse of a different color. There are certainly protocols for drug trials, if that's what it's talking about, and so that's not going to be going on just in the average day in the average medical practice. If the question is about testing the patient for the use of these substances before prescribing them, the statute certainly, or the bill doesn't prescribe exactly what needs to be tested for. There are certainly a number of commercially available through laboratory drug panels, and I think Dr. Singh mentioned this. I think it's an excellent idea if you're going to be embarking on prescribing these drugs for this patient population, not the typical surgical, post-surgical patient, but these chronic non-malignant pain patients, that they are tested periodically to ensure that, number one, they're not taking more than they should, and number two, they're not taking drugs that you're not prescribing.
Right. Okay. Okay, well, I think we had another couple questions that I think we'll just answer by emails. Dr. Singh, fantastic job. I learned a lot. You've got a great positive and organized perspective on making lemonade out of lemons. And Lester, as always, a beautiful analysis. For all of you attendees, if you have any questions, we'll be answering them by email. I have them on the screen in front of me. There are several. Also, if you want Dr. Singh's draft protocols, let us know. We have a couple of requests for those, I see. Finally, we're going to be representing this live on Monday at 5 p.m. I'm sorry, next Monday at 7 p.m. So if you'd like to attend, we'll be smarter next Monday at 7 p.m. Or please send your friends and colleagues. Thank you very much for attending. We appreciate all you're doing, especially as physicians in Florida working with these new rules. Thank you.